Welcome back in another part 5 video of chest X-ray in ICU HDU. This is the continuation of video in the part 4 where we have discussed some chest X-ray in ICU and HDU settings. We will discuss few more X-rays in the part 5. So let's start. First is coming to aspiration. Aspiration is there is an increased rate of aspiration in the ICU and HDU patients because ICU and HDU patients are sick and they have sometimes they are intubated, they have a diminished cough reflex, they sometimes use sedation, there is altered mental status, there is a RAS tube feeding going on for the ICU HDU patient, and sometimes gastric slowing or ileus is there. That may be due to because the disease itself, or maybe the drug sometimes we use that can also cause the gastric slowing and ileus. These all risk factors, intubation, diminished cough reflex, sedation, they all cause increased risk of aspiration, and aspiration is one of the most common problem that we see in the ICU and HDU patient. So what is the manifestation of aspiration? This includes aspiration can cause chemical pneumonitis, it can cause frank pneumonia, and it can also cause airway obstruction. But what happens in gastric content aspiration? Aspiration of acidic gastric content can be fatal, resulting in a severe chemical pneumonitis and ARDS. So gastric content aspiration, we know it's having very low pH, highly acidic. So aspiration of gastric content can cause chemical pneumonitis and ARDS. Coming to the site of aspiration, aspiration is more common on the right lung. It is just because of the gravity dependent mechanism, and in case of upright, when the patient is upright, the lower lobes, right, is more than left affected. In case of supine, most of the patients are bed bound, supine patient. So what is the most common site of aspiration? Again, right lung is more commonly affected. Superior segments of the lower lobes or posterior segment of the right upper lobe is most commonly site of aspiration is there. Okay, and this is typically seen in the patient with altered sensorium, like for example alcoholic patients, intubated patient, and the patient with CVA. Here we can see in the right lung this part, posterior segment of upper lobe. Here we can see. So this area, right lung, is the most common site of aspiration. This is the posterior segment. Here we can see this area is a posterior segment of upper lobe, and this is superior segment of lower lobe. This is the most common site of aspiration in case of patient who have the high risk of aspiration. Right lung is most commonly involved, but sometimes left lung is also involved. But what are the commonly site are there? It is superior segment of lower lobe and posterior basal segment of the lower lobe are the common site of aspiration in left lung, although this is not a very common site. Right lung is most commonly affected in case of aspiration. So how the X-ray will look like? The radiographic abnormalities we can see in case of aspiration is patchy ill-defined shadow here, and we can also get nodular opacities, and we can also get frank consolidation in the dependent area of the lung where there is a aspiration is happening. Alright, so what is the GGOs? Ground glass opacity or opacification we most commonly see. GGO is an area of increased attenuation that looks more bright shadow in the lung on CT or chest X-ray sometime, with having preserved bronchial and vascular marking. So here we can see this area is a normal lung, and this area is having ground glass opacity. In this opacity we can delineate the vasculature as well as the airway. So although this area is bright, but this is a disease or pathological area. So it's a very non-specific sign with a wide etiology including infection, chronic interstitial disease, and sometimes acute alveolar disease. Here we can see the example of how does ground glass opacity looks like. There is a wall and different glasses are put of the different density, and they are causing a different shadow. So the same process happens in the lung. So there is a normal lung, and as the disease process advances, as the infection inflammation process goes on in the disease part, this opacity becomes obvious in the case of infection, inflammation, chronic interstitial disease, or acute alveolar disease, and it is most commonly seen in the CT, usually not very well seen in the chest X-ray. Coming to pulmonary hemorrhages, pulmonary hemorrhage could be localized or diffuse. Why the pulmonary hemorrhage is happening? Because of injury to the alveolar microcirculation that lead to the bleeding into the air space. What are the causes of pulmonary hemorrhage? Could be because of autoimmune diseases, could be bleeding diastasis, could be vasculitis. Some certain drugs can also cause an infection, sometimes invasive aspergillosis, mucormycosis. blood thinners and heparin. Patient in the ICU and HDU are most commonly because of sometimes because of DVT profile axis or because of some disease condition itself, they are on the blood thinners or heparin. So that can also cause pulmonary hemorrhage. There may be infarction, there may be pulmonary embolism or stroke, that can all cause pulmonary hemorrhage. How to diagnose a patient in ICU? There will be acute fall in hemoglobin and we can see the new onset parenchymal shadow in the lungs. In intubated patient, when we do the tracheal or ETS spirit, we can get a frank blood while suction, and that may be associated with the deranged coagulation profile sometime with thrombocytopenia. Now coming to the pulmonary thromboembolism, the prevalence of pulmonary thromboembolism in critically ill patient is as high as 27%. So what are the risk factors? Obesity, past history of venous thromboembolism, cancer, immobilization, trauma and recent surgery. But the ICU patient, they have exposed to additional risk factors like there is a sepsis, sometimes the patient are on high vasopressor use because of unstable hemodynamics. We also use some pharmacological sedations, and there may be mechanical ventilation also in central line catheters, renal failure. These all have an additional risk factor for developing pulmonary thromboembolism in the patient who are admitted to the ICU and HDU settings. So what happens in pulmonary thromboembolism? There is a thrombus formation in the lower limb. Here we can see that propagates through the systemic circulation, and now it is here we can see through the is the embolus. This is going in the heart and through the pulmonary circulation it is going in the lungs, ultimately causing damage. Here we can see here there is a multiple infarct, multiple emboli in the lungs causing the infarct, pulmonary infarct. Alright, and if this embolus is large enough to cause here of obstruction at the bifurcation of pulmonary trunk, it will cause cardiovascular compromise, because ultimately there will be cardiovascular compromise, ultimately lead to the collapse of the patient. In these patients are hemodynamically unstable. Alright, so this patient have a severe hypoxia, hypotension. So saddle type embolus will be obstructing the main pulmonary trunk, and ultimately it's a very dangerous and very fatal condition sometimes. So we have to be very careful regarding pulmonary thromboembolism, and we have to treat accordingly. Alright, so what are the signs we get? We can, in the X-ray, we can have the Westermarck sign, we can get a Fleischner sign, we can have a knuckle sign, and we can have a Hampton hump. So one by one, what we see, Westermarck sign, it is a regional pulmonary oligemia or focal oligemia. Here we can see this is a focal oligemia, because once there is an embolus is either distal to that, there is blood supply is not there or blood supply is poor. That leads to the finding of Westermarck sign or pulmonary embolism. How to compare, how to look for this we have to look for, we have to compare with the other side. Here we can see there is a bronchovascular marking vessels we can see here, but here this part is looking oligemic because of the poor blood supply. Another is Fleischner sign. What will happen? There is an enlargement of the proximal pulmonary artery. This one, this is a Fleischner sign. And knuckle sign, it will be abrupt tapering of the occluded pulmonary artery. This side, this is typical, having a typical knuckle shape appearance in case of occluded pulmonary artery causing the pulmonary embolism. Hampton hump, it is a wedge shape opacity arising from the pleura sometime, most of the cases, and it is a peripherally located because of the lung infarct, because the distal part has lung parenchyma is infarct because of the pulmonary embolism, and it will have, you can see it is a wedge shape opacity here, and but it will not have a air bronchogram, because if there is air bronchogram is present, we know that that is a sign of consolidation. So in this way we can have a differentiation from this Hampton hump and the consolidation. So how to diagnose? We have to diagnose pulmonary embolism by CT pulmonary angiography is a gold standard for diagnosis of PE. Coming to the barotrauma, particularly the pneumothorax remains a common ICU complication. Other forms are like pneumomediastinum, pneumopericardium and pneumoperitoneum, subcutaneous emphysema and interstitial emphysema. Sometimes even a small pneumothorax can rapidly progress to tension pneumothorax in ventilated patient due to the positive pressure ventilation. The patient who is already receiving positive pressure ventilation and on invasive mechanical ventilation, if there is a small pneumothorax, that can rapidly progress to the tension pneumothorax and cause cardiovascular compromise. So we should always look for typical ventilator settings that, and we should frequently monitor the patient who are on the ventilative support to look for the barotrauma and appropriate ventilator settings that settings will not cause barotrauma. So any patient who is on invasive mechanical ventilation must be evaluated properly, frequently, very frequently, for his hemodynamics, for a chest auscultation, vitals, pulse, BP, saturation, and on the ventilator settings to look for the peak pressure, peak airway pressure that we look in the on the ventilator. That will give some idea about the what's going on. All right. So in barotrauma, here we can see one is pneumothorax. This area here is you can see there is air in the pleural cavity, and it is a pneumothorax. In CT, it will look like this. But what happens in case of ventilated patient or the bed-bound patient? In the supine position, air collects in the least dependent anteromedial pleural space, resulting in the increased radiolucency or black shadow at the bases and sharply elongated cardiophrenic and costophrenic sulci. That we all know that is called a deep sulcus sign. Here in the pneumothorax, we will look here this sign. Normally here, this will be a deep sulcus sign here. So in pneumothorax, we can see in ICU and supine patient a deep sulcus sign we can delineate from this side. And this is the pneumomediastinum. Here we can see there is a thin rim of air in and around the pericardium. Okay. So there you can see the left heart border, there is a thin rim of air. So this is the pneumomediastinum. And here we can see air in the subcutaneous plane. So it is a subcutaneous emphysema. Okay. So in the CT scan, here you can see air is there, and also this is a typical of pneumomediastinum. Here you can see air in the pericardial cavity and pneumothorax also. All right. So we have to be very careful, and we have to be frequently we should very frequently assess the patient who are on ventilator to look for all these complications. Another is pleural fluid. Pleural fluid in ICU patient is mostly transudative, and the costophrenic angle is often not blunted. We should remember it on the supine radiograph, and the pleural fluid may only demonstrate a veil-like opacification from the layering of the pleural fluid. Pleural fluid will form a layer, and that is because of the gravity dependent. It will be the posteriorly located, and what we see CP angle blunting that we see in the PA film will not be there, and it is a veil-like opacification. Veil-like means it is just like a ghungat, parda or nakab. Here we can see the girls, sometimes women use for cover their face. So this is just like a veil-like opacity you can get, and the apex in the most dependent in the supine patient, and the fluid may manifest as an apical cap sometime. In the supine patient, we can have an apical cap because the fluid will be collected here. So what happens in upright film? Upright film, the fluid will be collected in the costophrenic angle, causing blunting of the costophrenic angle. But this fluid will, because of the gravity effect, it will be in the supine film, will cause a veil-like opacification shadow here. All right. So what happens in PA film? Again, we can see here in the PA film, this is a pleural fluid. This will be having a typical meniscus sign. We all see it will look like this. But the same fluid, when the patient lies down in the supine position, here we can see the pleural fluid is forming a layer in the pleural cavity and causing this kind of shadow. All right. So this is a veil-like opacification. We should be very careful for the looking for the pleural effusion in such patient. Here we can see this is a veil-like opacification, this area, and in the right mid and lower zone, if you do a CT scan, this is the area of effusion. This part is, there is a effusion and there is a collapsed lung here. Fine. So axial CT image shows moderate right pleural effusion. Coming to the tubes and catheters, one major use of radiograph in ICU is to check the position, because we sometimes patient gets intubated, and sometimes we put a many lines like central lines, sometimes dialysis catheter. So we should always do X-ray to check the position and to evaluate any complication related to the insertions. So this is very important to remember what is the normal course and where the tip lies and what complication can arise. So if patient we put a nasogastric tube, the course should be in the midline along the mediastinum, past the carina, past the diaphragm, and tip should be 10 cm past the gastroesophageal junction in the stomach cavity. Or what complications can be there during placement? It can coil in the mouth, it can go too distal in the stomach, it can cause in the pleural cavity, it can cause enteric perforation sometime. And what complication arises? It can cause aspiration, the tube can migrate and tube can break also sometime. Endotracheal tube, it should be there within tracheal lucency, and it should be 2 to 6 cm proximal to the carina. What complication arises? Sometimes there is a bronchos intubation, sometimes there is a esophageal intubation also, that can also cause tracheal perforation, esophageal perforation, and complication can arise, can be a barotrauma or tracheal stenosis. Another is central line we put. So it should be in the right internal jugular into superior vena cava. Catheter should be vertically oriented via right and left subclavian vein into superior vena cava. Catheter should pass below the level of clavicle and then curves downward. We will see in the another X-ray what is the normal position of the central line. So its tip should lie in the lower superior vena cava above the cavo-arterial junction. Complication during placement can occur like incorrect intravascular placement into the right atrium, ventricle, sometimes in the azygous vein also. It can go extravascular placement may be there in pleura, mediastinum and pericardium. And complication that happens due to daily use, it can migrate somewhere, okay, in the systemic circulation sometime if it is not fixed properly. Dialysis catheter, same as the above, its tip should lie in the cavo-arterial junction. Complications should be the same. And chest tube we sometimes we put for the pneumothorax, and we should we put for the large hemothorax or effusion. So in the pneumothorax it should be anterior superiorly placed, and for the fluid drainage it should be posterior inferiorly placed in case of effusion, hemothorax or empyema. What complication can be there? It could be malposition, it can go into lung parenchyma sometime, it can go into fissure, it can remain in the subcutaneous tissue itself, it can cause in the mediastinum, and sometimes be pericardium, myocardium also, and can also go in the diaphragm, or sometime because of it can cause injury to the diaphragm also. Complication that can happen sometime because is re-extension of pulmonary edema sometime we see. So coming to the endotracheal and tracheostomy tube, the tip of the endotracheal tube should be located about 5 cm above the carina when the patient head is in the neutral position, because what happens, the neck flexion moves the tube inferiorly by up to 2 cm and neck extension moves it by superiorly by the same 2 cm. So it should be taken care. It should be the tip of endotracheal should be located 5 cm above the carina, because when there is a neck flexion, there is a 2 cm inferior displacement of the endotracheal tube, and when the patient extends his neck, it is a superiorly 2 cm. So, and what problem arises? Sometimes there is an intubation of main bronchi, most frequently right sided, that may result in subsegmental and segmental collapse or complete collapse of the left lung. There is also right lung at risk of pneumothorax from overventilation, and the too high sometimes there is, if endotracheal tube is too high, it can cause extubation, and it can also damage to the larynx. And sometimes overinflation of endotracheal balloon cuff can cause tracheal stenosis, or sometimes called acute rupture. Here we can see this is the endotracheal tube going in the mainly right bronchus, endotracheal tube and tip in the right main bronchus. Here we can see, and leading to the, here we can see complete collapse of the left lung, because left lung is not aerated, so it get collapsed, and right lung is risk of barotrauma because of the excess ventilation, over ventilation can develop pneumothorax. After this tube is repositioned, here we can see this is the trachea, this is the carina, this is your right main bronchus, this is left main bronchus. Now this lung is open. All right. So we have to check always after tracheal intubation the position of the endotracheal tube. Now Ray's tube, the tip of the feeding tube Ray's tube should be ideally in the antrum of the stomach or distal to it. It should be post-pyloric to reduce the risk of aspiration. The proximal side holes of nasogastric tube should extend beyond the gastroesophageal junction. Sometimes there you can see the malposition nasogastric tube, epifilm. Here we can see there is a nasogastric tube, Ray's tube traveling in the, here we can see is a tracheal through the right main bronchus and ultimately causing the puncture to the pleura and leading to, here we can see the pneumothorax, this part. So this is tube, Ray's tube has gone all along the right main bronchus and also have damaged the pleura, causing a moderate pneumothorax. Here we can see this side. All right. So, and what here in this film, here we can see another patient showing a Ray's tube terminating in the, here in the right main bronchus. So even also we should always, because sometimes there is unconscious patient or the very sick patient, we should always get an X-ray done once a Ray's tube is placed properly, and if you have any doubt that where the Ray's tube is, so do not start any feeding before X-ray is done. Okay, do an X-ray, check the position of Ray's tube, then start feeding or medications. Coming to the vascular catheters, right internal jugular vein catheter, the catheter is vertically oriented. Here you can see, if it is central line is placed in the right internal jugular vein and its tip is there, the tip is projected over the anatomical location of the superior vena cava, approximately 1.5 cm above the level of carina. Here this is the carina, here you can see, and here is the catheter tip. This is the normally located, this is the normal position of internal jugular vein catheter, right? Alright, this is an ideal position for right sided catheters for fluid administration and venous pressure monitoring. Okay, so now if you do a right subclavian vein catheterization, then the catheter should pass below the clavicle, it should go pass below the clavicle, here you can see, and the distal catheter is oriented vertically. This should be here. It should not go like up, it should not go coil here, it should be going down, and the tip is located 1 centimeter above the level of carina. Here you can see this is the carina, approximate distance is 1 centimeter. So this is the normal position of right subclavian vein catheter. What happens in left subclavian vein catheter? The left subclavian catheter is located with its tip below the level of carina. Here as you can see, it should go all around this and it should be below the tip of carina, this point. So when we do a center line for a patient admitted in the ICU in HD, we should always do a X-ray after that to rule out that the number 1 for catheter is in the right position, and number 2 to look out any pneumothorax or any injury that has happened during the procedure. What happens in the PICC line? If this peripherally inserted central catheter is correctly located with its tip of the at the level of cavo-atrial junction, PICC line are usually there should be here. Okay, they should be at the tip should be at the level of cavo-atrial junction. Approximate the height of the 2 vertebral bodies below the level of the carina. It should be at least 2 vertebrae. Here you can see this is the carina, vertebra 1, vertebra 2. So approximately it should be below the carina, approximate 2 vertebrae below the carina. And this is often considered as a preferable location for the long-term catheter. So PICC line are usually in the long-term care. Sometimes, so this is the preferable position, preferable location for long-term catheter like PICC lines. Coming to the chest tube and pleural drain, we know that for the tip of tube, in case of pneumothorax, it should be towards the apex, and for the fluid drainage or empyema or a hemothorax, it should be toward the bases, lung base. Here we can see for pneumothorax, here we can see this is the area of pneumothorax, this is here you can see the collapsed lung, this is the collapsed lung, and the tip is right pointing towards the superiorly in the pleural cavity. In case of pleural effusion or empyema, this is the pleural effusion, here we can see, and we have put a drain, and that should be located, the tube should be placed towards the lower part of the pleural cavity for the good drainage, and there should be no kinking. Okay, so this fluid can be drained properly. So to conclude, the take home message is compare with as many as previous radiograph as possible to look for new opacities, migration of opacities, and if any previous medical history is there or not. Then note the difference in the technique, patient position, rotation and penetration. Always, this is the very, we have discussed already that technical aspect is always important when commenting a chest X-ray film. Document every new opacity and lucency. If there is a new opacity is there, so we should always put a note, and we should make a habit to make a diagram and put a new opacity and lucencies if there. Register any migration opacity. We should also notice that if any opacity migrate or if it is disappears, then we should also note that also. And we should monitor change in the mediastinal contour that cannot be explained by the difference in technique or rotation. We should, this is very important, mediastinal contour we should always look for, vascular pedicule we should look for, because we in the previous discussion we know that enlargement of vascular pedicule is an early sign of interstitial edema sometimes. So we should always look for if the mediastinal contour is enlarging and vascular pedicule is enlarging, in that can be a sign of fluid overload, and that can be taken care early. Okay. We should always mention the site of insertion. We should look for the course and tip of all catheters, tubes and lines we have just discussed, and we should check for any prior CT thorax if available for the any pre-existing COPD or fibrotic lung disease. So if the patient is having done previous CT is available, so that should always take look for any pre-existing COPD or any fibrotic or chronic lung diseases for that matter. Okay, and wherever possible, get the detailed clinical information. Always, this is a very important clue. We should always have a detailed clinical information, detailed clinical history, proper clinical examination, and then all these radiological chest X-ray and CT findings. So to conclude, thank you so much, and share among the friends who are involved in the patient care in the ICU, SD, and who are keen to learn the reading in the X-ray also. So, and comment any topic if you want for the description, for a brief description. So you can put your comment there in the comment box. Okay. Thank you.